Hello everyone, in this video we are going to discuss about hyperkalemia. Hyperkalemia is the clinical conditions when the serum potassium level is more than its normal baseline. The normal is 3.5 to 5 milliequivalent per liter. If it is more than 5, then we call it hyperkalemia. It is rare but very dangerous, so we should be concerned about it. More than 5 to 6.5, it is usually asymptomatic. It is only diagnosed in the ECG, but if it is more than 6.5, then there is the risk of arrhythmia, so we should be concerned. Let's say some of the ECG finding. If it is more than 7, then there might be tall tented T waves, and if there is more than 8, then there might be prolonged QRS interval. If it is more than 10, then the sine wave pattern will be seen. So let's see the treatment. We have three headings. One is physiological antagonisms by using calcium gluconate. Another is pushing the potassium intracellularly and excretions of potassium. First, let's see about the antagonism by the calcium gluconate. Calcium gluconate can be given IV injections like 10% over 10 minutes and 10 ml. 10% of the calcium gluconate 10 ml over 10 minutes. It can be repeated after 10 minutes. It is given to stabilize the cardiac membrane. There is the risk of ventricular fibrillation, tachycardia, arrhythmia, so it helps in the stabilization of the cardiac membrane, but it doesn't reduce the potassium level. And next is pushing the potassium intracellularly using the insulin plus glucose. Regular insulins can be given 10 to 20 units and glucose 25 to 50 grams. There is a risk of hypoglycemia while giving insulin, so we should give 5% dextrose after the giving insulin. Another is by injection sodium bicarb. It can be given like 50 to 100 ml of 75% sodium bicarb over 10 to 20 minutes. And other is beta 2 agonist salbutamol. It can be given by either by the nebulizations or IV. Nebulizations 20 ml in 4 ml normal saline or IV direct 0.5 mg. And another is excretions of the potassium by using loop diuretics. Cation exchange reagents of potassium and calcium like sodium polystyrene sulfonate and calcium polystyrene sulfonate. And dialysis can be done to reduce the level of the potassium. It is usually done 35 milliequivalents per hour. Now let's see some of the fact. But if the pH of the patient is high or low and he is admitted in the ICU, so we should be concerned about the hyperkalemia and hypokalemia. For example, there is one patient with diabetic ketoacidosis. His pH is 6.9 and serum 6.2. He is in metabolic acidosis. So how can we correct potassium? Usually if we see it is above the normal, above the 5, but we have to calculate actual corrected potassium in this patient. So how can we calculate corrected potassium? We know the normal pH is 7.4. It is actually 7.35 to 7.45, but normal we take normal 7.4. We have to see 7.4 and 6.9. How much reduce is pH? Every 0.1 decrease in pH, the serum potassium increased by 0.7 milliequivalent per liter. So there is 7.4 minus 6.9, there will be 5. So 5 into 0.7, it is 3.5. So our corrected potassium is 6.2 minus 3.5, it is 2.7. So we should treat as hypokalemia, not hyperkalemia. Or you can use the formula corrected potassium equals to potassium minus 0.7 into initial pH minus final pH divided by 0.1. And let's see another case of vomiting. There is one patient with profuse vomiting. He is metabolic alkalosis with pH 7.7 and potassium 2.6. If you see just potassium, it might be hypokalemia, like it is less than 3.5. But we have to see there is every 0.1 increase in pH, the serum potassium decreased by 0.3 milliequivalent per liter. So there is 7.7 7 minus 7.4, it is 3. So 3 into 0.3, it is 0.9. So collected potassium is 2.6 plus 0.9, it is 3.5. It is the normal, so we don't require treatment for potassium. Rather, we should treat the alkalosis part in this by giving fluid and all. So thank you very much.